Happy Wednesday, everybody, and thank you for joining us for this webinar on the medical technology perspectives on the 10-year cancer plan for the NHS. I have with me Bern Sadler from Celsius 37 and Warren Poon from LOC. Firstly, Bern, I think we'll introduce ourselves and say where we're from and what our companies do. Why Celsius 37? Why is it called Celsius 37?
Well, when Celsius 37 was founded like 20 years ago, we had the patient in mind. So it was about, already back then, it was about data transparency, data belonging to the patient, so that patient in the center of its interest, more or less. So we are trying to find a name which expresses the equilibrium for people, so which is the body temperature. So we decided to name this company Celsius 37.
Cool. And it's a German company?
It is a German-based company, so we are located in Mannheim, which is southern Germany.
But you do projects all over Europe?
We do projects all over Europe. We have about 30 to 40 people working for us, lots of people programming for us, doctors, medical experts, and so on, lots of people working in quality control. So we are focusing on oncology. Actually, we're doing web-based solutions in healthcare only. So our focus is healthcare IT. And we're using web-based systems for doing this. And as I said, the strong focus is oncology systems, like oncology information systems, tumor board organization, as we call it, or medical team meeting, as it's called here in this area. So we are working around that.
Oh, brilliant. And Warren, you're from LOC. What is LOC?
So LOC stands for the Leaders in Oncology Care. It's a private healthcare provider in London which provide oncology treatments to private patients in the UK. We got 3 sites, one in Harley Street, one in St. John's Wood, and one at Chelsea that's been recently opened. And we got a privilege to have one aseptic compounding unit in each facility, so we're able to achieve a very high turnaround volume of patients at a very short period of time. So yeah, it's very exciting.
And you're the lead QA and aseptic pharmacist.
And I'm the lead aseptics QA and aseptics and QA pharmacist. And I have got a role in quality management system and ensuring the good manufacturing practice guidance are followed. And I have got a role in education and training in all aspects of the aseptic services. And I've been primarily employed to implement BD CATO, and I execute the validation master plan of the system.
Cool, cool. And the reason why I'm here is I am a pharmacist as well by background, but I work for BD CATO, and it's something that we actually all have worked on together on individual projects. And what this webinar will cover will be the projects that we've all worked on together in the United Kingdom. Just to set the scene, as both Warren and Bern are with us today, NHS Improvement commissioned Deloitte to do a national review of septic services last year. And in March 2018, that report was published. It was presented at the CPC conference, and it's been in discussion amongst the septic community for quite some time now. For those of you that are not familiar with the NHSI report, there were quite a few things that they found when they surveyed the 180 septic units throughout the United Kingdom. Out of 649 isolators or workstations, 403 were near end of life. Total parenteral nutrition is growing by 6.3% every year, chemo by 4.8%. Clinical trials by 1.2% and antibiotics by 0.9% year on year. However, there's about 15 to 20% staff turnover in the septic community alone, and that's higher than the NHS average, with up to a 14% vacancy in particularly the Band 7 aseptic pharmacists, which is usually the regular staff members that you would see in the aseptic suite. And because of all this, 41% of units throughout the country are actually reporting doing overtime. And 60% of facilities perceive lack of staff capacity prevents them from offering even further services. So we've also got antibiotics, which actually a lot of the aseptic suites are not currently doing because they don't have the capacity to take it on. 35 aseptic units throughout the country would like to make antibiotics, but they're already struggling to cope with the current chemotherapy and TPN demands. We know that nurses, based on our studies, actually take up to 10 hours a day making medications on the ward. So that's a lot of work that we could, the pharmacy aseptics could actually take on if they had the bandwidth. So I guess considering the current situation, is there a way forward? And today we're going to look at 2 cases that all 3 of us have worked on in the United Kingdom. We're going to start with Warren.
Sure.
So Warren, you maybe tell us about your experiences and what processes you were trying to fix.
Sure. So just a bit of background about what pharmacy septic services is, because I appreciate not all the audience has got exposure to pharmacy septic services. So aseptic services basically is about, by means of using some specially designed facility and equipment, and by use of special dose manipulation techniques by the operators under a very strict control environment, to produce some products that is free from foreign matters such as particles and microorganisms. So there are a few ways that you could do it is through aseptic technique, so no touch technique on the critical zones such as the needles that goes into product vials, or membrane filtration, so you filter your product into the final dose container to remove all the microorganisms and most of the particles. And finally, you could do a end product sterilization, so making use of autoclaves and radiation. So that's the background of aseptics.
Why is it important in terms of chemotherapy?
Oh yeah, because
Can't you just pull it off the shelf and
yeah, because you will appreciate a lot of oncology products, they are cytotoxic, or they could be harmful to the operators who prepare the medication. So there needs to be a strict environment and control environment where these preparations are prepared. Otherwise, the operators exposed to these harmful substances.
Mm-hmm.
And also often oncology patients are immunosuppressed. So you wouldn't want to introduce any microorganisms in the preparation that you're administering to the patients. So we aim to prepare anything or the medications that's supposed to be administered to this group of patients in a sterile manner.
What do you think is the traditional way of making chemotherapy in the septic unit throughout the UK? Like, is it paper-based? Can you explain very briefly what were your processes were before?
So the traditional way of preparing chemotherapy in most of the units, making use of paper-based, very heavily relying on paper-based systems. And it's a traditional way, and you would have one operator draw up a volume, and then a second independent operator who would check your volume to confirm that the correct volume has been withdrawn and expelled into the infusion bags. So this is what we call a volumetric manipulation of the dose. And we got a lot of aseptic services demand in the UK mainly because of the NPSA Alert 20. And in these alerts, it's found out that a lot of the specification provided by medicines manufacturer or any evidence that is provided to clinicians are not really comprehensive enough to tell the clinicians how to prepare the medicines as a ready-to-administer form. Also, prescriptions are found to be very incomplete and ambiguous, and does not contain the correct information such as the diluent, the final dose container, rate of administration, etc. And
I've got here,
yeah.
You've got error types. So according to the PASAG, the Pharmaceutical Aseptic Services Group, human error contributes to about, labeling errors about 30%, 20% of transcription errors, 15% of selection errors, in all categories, about 70% of errors are attributed to human factors. And do you think paper, as manufacturing chemotherapy on paper, contributes to quite a lot of that?
Yes, of course. So just picking transcription as one of the biggest challenge in aseptic services. Traditionally, you rely on an operator to manually transcribe the batch numbers, expiry dates of a raw material onto a paper-based worksheet. And this is a very manual process and is subject to human errors. So if the wrong information has been transcribed from the prescription onto the worksheet, then a wrong dose will be prepared and the patient is put at risk.
Makes sense.
Yeah, so a lot of these errors are related to human errors, and by having an electronic workflow system or embracing automation technology could potentially eliminate these kind of errors. But I just want to stress that having automation technologies or electronic workflow system is only one of the many ways to control this risk. And there's a myth about, having electronic workflow system or automation they are risk-free, and we're safe to prepare medication using electronic workflow system without worries. But this is not true. If you decide to go down the route of having automation, you're merely transforming what you have got, the existing risk, onto a different platform and make it more manageable.
More manageable, and would you say increases transparency and traceability of those errors as well?
Yeah, definitely. So, and also you remove the responsibility or the importance of having a robust training. You rely on automation, so you remove the human errors element from the whole process, and you got more engineering control and barriers to prevent errors from happening.
One of the arguments I've always had, even when it comes to dispensing errors, is that it's our job to check, and if we can't check, then what are we good for? This is one of the things that frequently comes up, especially if it's a non-healthcare person that's commenting on this. What are your thoughts on on that comment?
So I think is a fair comment that is a responsibility for the pharmacy staff to make sure what has been prescribed is transcribed onto the worksheet correctly and the dose is prepared safely and correctly. But also clinicians who prescribe medication should have also responsibility to ensure what they prescribe. The prescription is complete and the prescription is very clear and have contained clear instructions and instructs the staff what diluent, let's say for example, the drug should be put in, rate of administration should be clear. So it's not just pharmacy responsibility to uphold patient safety, but everyone's responsibility. So
do you think also lack of staff, like the NHSI report has pulled out, and as well as increased workload, all these things, no matter how careful you are, contribute to human beings making error?
Yeah, so naturally, since the NPSA 20 alert comes out, everyone wants ready to administer doses to be delivered to their door. So obviously this increased the workload to pharmacy aseptic services. And I won't blame the pharmacy staff for making more errors, because the more you do, the more chance you can make errors. It's human nature to make mistakes.
So what was you implemented an electronic system? I guess, what benefits firstly did you see, and what changes, and what were your challenges in doing it, and why did you choose to switch from a paper-based system to an electronic system in the first place? Yeah,
so back in 4 years ago, we're still using a paper-based system, and we found a lot of process repetitions, and we found our pharmacists and technicians are heavily involved in aseptic compounding pathway. And we would really want to move away from these and free up pharmacists and technicians' time for the clinical task or project improvements, projects works. So we found BD CATO because BD CATO is a system that fully embraced barcode technologies, so full traceability and auditability. And it's a paperless system, so it's a less chance of having manual transcriptions. So it's a huge chunk of mistakes, errors that has been eliminated. So that's why we've chosen BD CATO as our electronic workflow system. Back in 4 years ago, there were 9 compounding steps from the stage where we received the order to we send the dose out for patients' use. And with BD CATO, we at this stage we are already eliminated 2 big steps out of 9 of these compounding steps. So it's a very nice system, robust system. Just throwing out some figures, we are by conducting 40 doses study on efficiency saving studies, we're able to save around 2 FTEs. So we're not like we we just have not less busy environment, but we're able to take these staff out from the compounding suite for them to focus on clinical work and service improvement projects.
At EAHP, you presented this data at the European Association of Hospital Pharmacy Congress last year in Sweden.
Yeah.
I think you also mentioned that your compounding time reduced.
Yes, that's a really impressive and improvement in a key performance indicator. So on average, our key our turnaround time, that's when nurses finish assessing the patients to give a go-ahead to pharmacy aseptic services to compound a dose, till we actually send out the dose for patients' use, has reduced on average from 45 minutes to 22 minutes.
And your internal error rate, did that make a difference to, transcribing errors and internal error rates?
Yeah, so we essentially eliminated the transcription error because in hope of having an interface built in from the prescribing system to the compounding software BD CATO, there's no human involvement in this transcription process. So it's literally eliminated this transcription error. In terms of volume withdrawal error, so operators often can draw up the wrong volume, and it's often being discovered at the point of being withdrawn. So on average, before we implemented BD CATO, we've got about 6.5% of errors that is related to wrong volume being withdrawn. But since we implemented gravimetric functionality on CATO, we literally eliminated this volume withdrawal error.
Gravimetric, what is that? Sounds like gravy you go with.
Yeah, not that tasty. So traditionally, doses are compounded volumetrically when one operator withdraws the prescribed drug and a second independent operator check that the correct volume has been withdrawn. So with gravimetric functionality, what you could do is you do not need a second operator to do an independent check anymore. So by using a weighing scale, you would check that the correct volume has been withdrawn. And the system will not allow a wrong volume being withdrawn to proceed to the next stage. So that's why I said the system is able to error-proof these kind of errors.
And thing is, if you drop the wrong volume and you only discover it at the pharmacist check, it's too late by then. You have to throw away the whole bag or discard that particular dose. So that does help.
Cause a lot of wastage, yeah.
I mean, it sounds great, but were there any obstacles? I mean, it's...
Certainly, yeah. So yes, there are a lot of obstacles, and a bit of advice to facilities who would like to implement electronic workflow system or automation. You will see a lot of obstacles, and it will just keep appearing. And one of the biggest challenge that we face is when we implement BD CATO is how can we ensure that the system is able to cover what we do before. So how we tackle this is we do a very careful process mapping. So we map out the as-in process using the paper-based system, and map those particular tasks to the future to-be system, and make sure that the to-be system in BD CATO can cover all the activities that we do at the, before. We also do a very careful capacity planning. So capacity planning means you need to know what the unit workload is and what service demands your clinic or your healthcare provider setting requires your unit to output. So my advice to people who would like to go down automation route is, if you are a licensed unit or your workload is spread out very evenly throughout the day, there are capacity planning tools out there, published templates that you could use, such as the one available in the Yellow Guide written by Professor Alison Beanie. And this is a very good start to look at your own capacity. If you are a unlicensed unit that work under Section 10 of the Medicines Act, you don't have a license, where usually there's no typical day that is the same every day. Your system probably needs to allow a very responsive supply chain and to meet a bespoke demand that arises on the day.
You've highlighted something that the NHSI report also picked up on, is that capacity planning throughout the country varies. There's no set system, and that was one of the things that the report picked up that we need to address.
Certainly.
There's no standard way that all units are actually calculating, which then contributes to them being over capacity or not utilizing it properly. Were business cases like an issue? Because I think the first thing when we talk about BD CATO is like, it sounds expensive. Is that something that there was an obstacle that you also faced?
Certainly. It's difficult to get financial support from your CFOs or your budget holder. So my advice is, if you want to go down this route, is you have to prove to your CFOs and budget holders that the new electronic workflow system, this investment, is going to be paid out throughout efficiency saving and transform those efficiency saving in terms of cashable benefits.
So did you think that the investment was worthwhile? Did you, from what you paid for BD CATO and what you got back?
Yeah. Of course, I cannot mention the sensitive figures like the cashable benefit that we actually achieved. But as I said, we have achieved around 2 FTE savings. We achieved turnaround time reduction, wastage reduction, and we're able to campaign compound a lot easier, full traceability and auditability, and all these transform and translate to cashable benefits. And that's how CFOs and budget holders understand your project planning.
Is your CFO happy with it?
Yeah, so far so good.
So far so good, that's cool. I think some of the things that we've heard as well from other people that use BD CATO is that sometimes the mindset, I guess, we've used paper for years in the Septic suite, and the question is, why change? Why now? I think the NHSI report has highlighted a lot of those pain points. But for you, any advice about why change from paper, and what the difficulties you were? Did you face any difficulties getting some staff members in terms of this is how we did it on paper and this is how we're going to do it now with the new technology?
Yes, certainly. My team has got a lot of resistance when we decide to transform from a paper-based system to a paperless system. And I think it's down to you have to have a very careful change management plan. Because all of a sudden, if you change from a paper-based system to a paperless system, it's going to be a culture shock to the team. So what we have done at the LOC is we rolled out the system very slowly, step by step. First, we have to set up a test environment on CATO, where our
which
operators...
BD helped you with.
Yeah, very helpful. Where the operators will familiarize themselves with using the system under the test environment, and complete their accreditation competencies test using the test environment. And then, so there's no surprise on the day we go live, and they're all ready to go.
I guess that's normal if you're introducing any new system, isn't it? That's
Yes.
not any different, whether it's electronic or not.
Yeah. And another trick that we do is we actually dedicate a lot of time to gain system confidence. So we didn't roll out Volumetric functionality straight away. We spent about 14 months to understand the system and roll out Volumetric functionality on CATO first. We built up our confidence to the system, and then we roll out to have gravimetric manipulation. So this is the step-by-step approach that we have taken so that our operators are happy to use the system.
I think on average, BD CATO implementation in Europe takes about 6 to 12 months, but I think you chose to do it in 14 months, and
Yeah.
we supported you on that.
Yeah.
So it was something that you felt that, because you also need to change with the team, and the team
Yes.
needs to be able to follow in with the change. So even though it could have been completed faster, you have to bring the team along with the journey, isn't
Yeah.
it? Cool. Just a disclaimer, I used to work with Warren, so I've also used BD CATO as a pharmacist, and I worked at a hospital site that was external to LOC. I don't remember there being much resistance on our part. I think we saw it and we went, yeah, that looks good, let's do it. But every hospital is going to be different.
It's different.
Definitely. I guess, Warren, thank you so much. That was detailed, and that was about your experiences being frontline, having to implement BD CATO as a pharmacist. I guess this leads us on to the concept of Celsius 37 and why Bern is sitting here with us. And how does it translate into the bigger picture? So Bern, I think Celsius 37 and BD CATO were working on quite a large projects and quite a few projects throughout Europe together.
Absolutely.
I think the one that we've mentioned during the blurb of the webinar, whereby if you were a patient that was holidaying in Cork and you've been admitted to A&E, as you do sometimes on holiday, that your consultant in Dublin would be able to authorize your medical records so that your A&E doctor in Cork will be able to get it with a click of a button. I think if it's a Sunday at 3 p.m. right now, what happens is that since it's a paper-based system, there is a chance that you're not going to get all that information. And it flows all the way from diagnosis all the way to GP letters.
Exactly.
Do you want to talk about the NC a little bit briefly about some of the concepts of it?
Absolutely. As I'm the exotic person on this panel here, as I'm not a pharmacist, I can do a little bit more in the network direction here, because we're talking about networking right now. And
technology networking.
Technology networking. Exactly, and the people from Ireland, the committee which is running the NCCP, the National Cancer Forum, they have done a tremendously perfect job actually in defining the way how they want to set up their strategy on cancer on the island of Ireland. And they have introduced a central system which they called NCIS, the National...
Not the TV show, unfortunately.
Not that one, exactly. But the National Cancer Information System. And this system is connecting actually every hospital, every public hospital in Ireland. So we're talking about 26 hospitals in Ireland connected to each other. And the example that Davina just gave about a patient being delivered to a hospital somewhere in Northern Ireland and being treated by somebody in the southern part of the island, this is absolutely feasible right now. We are using a central database, so everything which is happening in the northern part of the island is centrally stored, and everybody else who is in charge of treating the patient further has access to the data. Of course, we're talking about a very fine-graded set of rights that those people have, including some means to override these rights in case of emergency, of course, with logging and audit things.
So in A&E, if that doctor in Cork wanted it, it's only consultant level access, isn't it, at the A&E level, that they would be able to ask the other consultant in Dublin?
Absolutely. It's an organizational point that you have to clear up before. But the concept behind that, and this is something that we also find in some other countries in Europe, like in Austria or Germany as well, is they're trying to get the competence of different doctors out to the patient rather than having the patient travel to the doctor. Sounds a little bit, like future, but it's there actually. It's like in Austria, we have a hospital trust that just want their patients not to travel further than 15 minutes to the next hospital. And they just want to give the competence of the people treating this kind of disease to the patient at this special site. So they do it virtually, of course. So the information is there centrally, and they just transfer the information to the doctor treating this patient at this hospital, even though he may not be an expert in this field, but he has the expert in the back. And so he can help. And also talking about a central patient registry, so to speak, the data is there everywhere where the patient goes. And this is very helpful. It cuts down costs in time, in travel time, so doctors don't have to travel. We're not looking at the patient travel time right now, but the doctor's travel times, of course. Traveling to medical team meetings, sometimes 1 or 2 hours, just travel time for having a 1 hour meeting and traveling back cuts a lot of active time of this specialist.
And saves patient time as well. I mean,
you're a
sickly patient with cancer, you don't really want to be going back and forth.
Absolutely. I just wanted to catch up on Warren's things that he just said, that at the end of the day, the CFO is here and he wants to have some numbers. And CFOs usually are not interested in the patient times because they are traveling anyway. But they are interested in the times of the doctors, and they're just interested in saving times. And it's not about the travel time only, but it's the quality of the treatment as well. Because if you have a system which is collecting all the data centrally, then everybody can avoid going into double examinations, for instance, because the results of the examinations are there on the tip of the hand.
So not doubling up on medical records?
It's not doubling up on medical records. Also, the documentation is there, so there's no lack of documentation things. There's no gap in the documentation. Everybody can look up what has happened to the patient. And this is also something that contributes to the overall quality of the system. So the treatment is more general. And
I think it's a different way of treating patients, isn't it? Right now, patients travel to different hospitals because those hospitals hold their records and information on paper. But also, even if they are electronic medical records, it's right now largely confined to that hospital. So you still have to travel to that hospital, the doctors have to go to that hospital to access that data. But what we're doing, what NCIS has achieved, and also some of the projects in Europe, you're saying is that because there's no restriction now in terms of where that information is located, the doctors can come to the patients rather than the other way around.
Exactly, this is the point. Of course, we have to obey the rules of data security and data safety, and that is for sure. But the systems that we have available right now, they are trusted, so we can really use them for things like this in the medical area. And this gives us the opportunity to really spread the information, or it's not really spread it, but the access is granted to everybody who has the right to access the information. And this is a quite valuable thing.
I think also in terms of granularity, like even like I know like GP letters sometimes from the hospitals, they can take a long time in the UK particularly to get to the GP. Sometimes 2 weeks after the patient has been discharged. With the NCIS project and what we've done, BD CATO and Cell Studies, and together, these GP letters are pre-formatted and in real time. When the patient gets discharged, they already get a copy of the GP letter.
Exactly. So the means in the system which are doing those letters, they collect information from the different data sources within the system. So they grab information out of the cancer record, they grab information out of some neighboring areas, and they kind of pre-collect the information for the, as you said, for the formatting of these GP letters. So all the information is there electronically, and also actually if the GPs had access to the system themselves, which is typically not the case, then a GP letter would not be needed anymore because the information would be there in a different form. It could be formatted for different people, so they could just see it like a compilation of the information which is useful for them. So at least we help them to create the letters pre-formatted, and they're sent out as soon as the patient is leaving the hospital, for instance. And what you said before with the central data accumulation, in many countries of Europe, it's the case that each hospital has its own numbering of the patients. So when a patient
hospital number, right?
Hospital number. So when somebody goes into hospital 1, he'll be treated as person number 1, and the hospital number 2 doesn't know about this person. The in-between step, what we're doing right now, is introducing like a unique patient number throughout the country. This is happening in Germany, this is happening in Ireland right now. UK, well, at least you have it in the trust as far as I know. But this makes sure that even if the patient travels from hospital to hospital, it's clear that this is the patient that we're talking about. So there's no confusion with the patient. So we have to make sure that is the case. And the systems that we are introducing to the community right now, they are supporting these kind of numberings. So we have something what we call patient index, general patient index. So we can kind of track the patient IDs, even if they travel across hospitals with different numbering schemes. And this is very helpful.
In your experience implementing the projects with us, with BD, what do you think were the biggest challenges in implementing something like that?
I agree with Warren. I mean, it's all about getting the team on board. And if you have like a pilot site where people are really eager to work with the system and they can see the chances, of course they also see the obstacles and everything which is happening, but they know how to treat them, they know how, or they learn how to overcome them. And they will be acting as multiplicators for the rest of the teams. So they are showing their teams inside the hospitals how to treat the system, and they're showing them the positive results or the impacts of the system. This is something that we really, in our cooperation, we put a lot of impact on, a lot of stress on, to find the right people, to really develop a working system together with a team that has to use the system, and then spread the news out to the others.
Find the early adopters, the ones
Find
that
the
can
early
see
adopters.
the whole process for what it is.
And I agree with Warren, there's a lot of reluctance using those systems. Depends a little bit on the age line. It's like the older people that have been, well, I'm allowed to say that as I'm the oldest here on this panel. But typically the ones that have been using their traditional systems for quite a long time, they don't see a reason to change because that's been working forever. But there are a lot of opportunities and plus points that you need to look at in the changing world of medical treatments right now, where it really makes sense to go for these kind of systems. And it's not only that you're changing workflows and processes to make them just electronically, going away from paper, which reduces errors and so on. You pointed out these things. But it's also, you get a lot of support from the systems. This is at least what we try to do from a technical point of view, to give the users of the system some support. Let's talk about decision support, things like this, which help them to define their decisions based on valuable data.
I think that leads us very nicely into our partnerships with IQVIA, also known as IMS Quintiles, one of the largest clinical trial companies in the world, as well as the partnership with IBM Watson. So for the audience that have not used BD CATO before, using the gravimetric technology, what BD CATO can do is actually measure down to the last milligram based on the density of the chemo drug itself, what your actual usage is. So if you use 32 milligrams of a drug, it will record that, and it's fully traceable and fully transparent. That sort of data is what's being fed into the CODE project, which is the collaboration of oncology data that's being spearheaded by IQVIA and BD CATO and Celsius 37 are partners of. What this data does, it feeds into a pan-European database, a bit like what the SACT information is meant to do, and helps build out a real data, like sort of population statistics of Europe as a whole. And that data is used to also feed into things like IBM Watson to better diagnose, because if you know that you get real life data as to whether this particular drug with this particular intensity actually does work, not based on a clinical trial that was done 5 years ago, but based on that particular population. I guess we don't really have that sort of live data right now, real-time data with real patients. It's completely de-identified, and the hospitals sign a contract with IQVIA to say that it's completely de-identified, but the data itself as to what usage for what tumor group, for what stage of cancer actually gets fed into that pan-European database for people to analyze and to see what the outcomes are. And I guess in the long term, this would be very useful for clinicians and consultants.
Absolutely, it's absolutely valuable. I mean, if we're talking about artificial intelligence support, this is what we're doing when we talk about IBM Watson and the mechanisms that IQVIA is using, then it's all about pattern recognition. So we're looking at a lot of data that we as human beings are not able to analyze anymore, but the machines are. And you can look at that on different scales. You could look at the pan-European database, like what IQVIA is introducing right now, which is very valuable because there's a lot of data in there. And you can look at these massive waves of data in a way that you check for different hormone status, different things that in combination give you a specific result for a specific patient that you have. And it's like if you look at your patient, like in a medical team meeting, and you look at the resolution that you would like to drive, you could have machines supporting you, telling you that somebody with the same problems like the patients that you have here appeared already on the database, not one somebody, but a whole group of somebodies. And you could look up like these somebodies have been treated with that and that therapy, and that would work or would not work. And this could be started on a hospital level with the data which is available in the hospital, which is a very small data set, of course. But it could also be driven out to the European or worldwide world and use data which is available to give you a much more structured data set on the, as a background with a more valid information content to work on. it's quite interesting. It's not giving the decision to the machine,
No,
as
yeah.
Warren's pointed out before, but it's giving
Clinicians better access
it's giving clinicians better access.
to up-to-date data and
Absolutely.
real data as well.
Absolutely.
Yeah, I guess that leads me on to some of the questions I always get when it comes to electronic workflows, automation and technology in general is even when I talk to people on the planes or friends, they say that is automation and this electronic workflow, are they going to replace nurses? Are they going to replace doctors? Are they going to replace pharmacists? Because if that's the case, I don't want it. What are both your thoughts on that?
So I think definitely electronic workflow system and automation can free up people's time to be away from the compounding or seeing patients, and reduce the time required to do all this work. But we should see this in a different angle, and we're not just taking them away and let them do nothing, but we're actually relocating the resources to somewhere else that is more useful at the moment where you would want the resources to be. So it's not about just cutting people, it's about working more smartly and improve process efficiency.
I completely agree. By the introduction of those systems, you bring in an extended level of quality control, which kind of relieves people from doing that because they get the support from the system. We're talking about standardization as well. This may be, if I just may jump back 5 minutes, this may be a big obstacle as well if you're going to connect a lot of hospitals with the same system to get really the positive results out of that system. But we're talking about standardization. If those hospitals have been working with different processes, they should be standardized just to make the lives of all those people working in these hospitals easier. And this is something that you really need to keep in mind. It's more plus points than minus. If you talk about that, more pros and cons, but it has to be taken in mind. And also, I agree with Warren, going back here now again, we're changing the work life of the people that have been doing things before, like standard work that needed to be done, somebody had to do it, which was just taking time, but those people now can can work in other scenes and do more efficient or more interesting work, so to speak.
We've got statistics that show that 40% of nursing time, for example, is spent on doing administrative tasks.
If not more.
If not more, filling out forms, filing away papers. So from my perspective, anything that can automate that would be great. As a pharmacist myself, when I was an oncology pharmacist, patients really appreciated the time you spend with them. Most of our oncology patients are scared. They put on a brave front, but they're scared when they come in, and it's such a fast process. Everyone's so busy. And when you actually spend time with them, you get to know them a lot better. You get to build those relationships. If I could have more time to do that, I think that's what makes me want to go to work, and also makes me realize a lot of my problems are #first world problems, when you talk to your patients. So I think if we could give NHS staff, doctors, nurses, pharmacists, more time back to spend with the patients, why not?
Absolutely.
And when you're a cancer patient, you don't want a robot to be comforting you. You want a real human being talking to you. Sure. And I think if we can do that, why not?
Actually, there are some concepts like in Switzerland, in the more private clinics, that are just at the moment turning their clinics around from a more medical treatment place to a place like a hotel. So they are really putting the emphasis on the service thoughts. And exactly because of that point, because people want to be in touch with somebody. They want to talk to the nurses and so on. But this can be handled anyway, because, if those nurses don't have to do stupid work, so to speak, they do have time to talk with the patients. It's more an organizational thing within the hospitals. How do I set up these environments so this is possible?
So I guess this is where we're going with the automation and things like BD CATO and how it's improved patient waiting times. Because traditionally, that 45-minute turnaround, like for in LOC, that patient will be waiting in the chair for 45 minutes. Yep. You've halved that, so that patient can. I don't think patients enjoy coming to the hospital receiving chemotherapy. If we can reduce that length of stay, that I think also helps with turnaround times for the chemotherapy day unit as a whole, with the oncology ward as a whole. So from that perspective, I think it helps with patient waiting times and diagnosis. I guess, do you guys have any closing statements for this webinar? Anything you want to leave the audience with? Any parting statements?
I think one keynote for all the audience is do not be afraid to embrace technologies. There are myths around risk about technologies, and actually don't be afraid, and it's worth the change management, the efforts and the resources that you put into the work, and because ultimately we all work to improve patient safety and the quality of care. So don't be afraid to make the change.
That is a good point, and I would just like to add on that. Completely agree with you here, but I need to add one thing. If you want to go that path, make sure that you have people on board who are really willing to drive that. So you need to have somebody internally really driving that project, being behind that. From the industry, we can support. We will support, definitely. We can help you. We have some experience from other projects and so, which will flow into your project as well. But there need to be people internally that are driving the project and they are really positive and willing to do that. It's worth it, we can tell you. But you need to have the right framework for doing this.
And I think from a BD perspective as well, like I'm a pharmacist, so there are quite a lot of pharmacists within BD, there are a lot of nurses within BD, and BD does that on purpose because it's, you know, when I was a pharmacist, talking to IT sometimes was a bit hard because it feels like two different worlds. So there's a lot of us within pharma and commercial companies that actually do understand what it feels like to be on the ground. So feel free to talk to us. You know, we're not averse to that as well. If there are any questions, the link that you registered in actually allows you to actually put in questions, and what we will do is that we will answer the questions after this particular webinar. Unfortunately, we can't see anything right now, but we definitely will get back to you. So thank you very much, guys. I know it was a long, it wasn't your usual lunchtime, but thank you very much for joining us and really appreciate it.
Thanks a lot.